Welcome back to another episode of From Print to Pod. I'm Dr. Donna Coriel, and I welcome Dr. Stephen Cohen. We are going to be discussing his article, From Scalpel to Strategy, Reinventing Surgical Education for the Next Generation, in which he argued that surgical education must evolve beyond traditional apprenticeship to incorporate strategic thinking, leadership, and modern skills like systems-based practice and technology integration, better preparing surgeons for today's complex healthcare landscape. Dr. Cohen, welcome. Can you tell us just a bit about yourself?
Thank you so much. Happy to be back. I hope everybody enjoyed the article. So, board certified in colon and rectal surgery as well as general surgery, now on year 31 in practice, teaching, training, educating surgical residents and medical students, and still working full time operating.
Fantastic. Okay, welcome back. So we're going to dive right into the questions and feature you with our several questions in a total of just around 15 minutes of an episode. So you describe a disconnect between training and reality. Can you share a personal moment, if you have one, when that gap really hit you as a surgeon?
Yeah, I mean, it was 30 years ago. Remember, we in academic setting, you're kind of protected in terms of seeing patients. You're not really in charge, right? The attendings are in charge. They're the ones that make the decision. But all of a sudden, you go from being the resident where you always have to ask your attending, this is what we want to do, or this is the plan. What do you think? To there's nobody to ask. It is just you. And many times I was faced with second guessing yourself, even in cases like a hemorrhoid surgery that I've done hundreds of before I became an attending. But it's the reality check comes in. And I will tell you, many chief residents that go into practice, I get those calls in the summertime. Let me just run a case by you. So it's really going from not making the decisions to making the decisions where you really learn to become a doctor in any field, not just surgery.
Yeah, it's definitely applicable across disciplines. So, if you could reinvent the first year of surgical residency from scratch, what
Mhm.
would it look like and what would be completely missing from today's version, if anything?
Yeah, I think the big thing is autonomy. I mean, it's the lack of autonomy. And sometimes I have to catch myself as teaching them. I can't do it for you, right? It's almost like me teaching you to drive. I can't be in the wheel for you. You have to hit the gas pedal. You have to know when to hit the brake. My daughter, before I took her driving, the question she asked me, she said, how do you know how far to turn the wheel if you're going left or right? Right? It's a feel thing. No different in surgery, no different if I'm teaching colonoscopy. If I were to reinvent it, I would give a lot more autonomy at the earliest level possible. And I will tell you that is the biggest criticism of most surgical residents today is we don't give them autonomy. Why is that? Many of us are paid, not me personally, but as a surgical attending, you're still paid on productivity. If you're slowing me down, I'm doing less cases. I like you, don't like you that much, right? So I can do the case quicker. I'm more experienced. You can do it with me. You can learn. But the real learning comes with you doing the surgery, me being the assistant and helping you if you need it, just like driving.
Yeah, autonomy is such a huge concept, and we're definitely all for it here at SoMeDocs. It's actually part of our mission statement. So, you mentioned we're training yesterday's surgeons for today's challenges. Can you give an example of a modern skill that should be taught but isn't?
Yeah, I mean, I think the surgical skills are one issue. Remember, how we did surgery 30 years ago, the way I trained is not the way we do it today. For example, laparoscopic surgery in 1990. I remember being presented the first laparoscopic gallbladder. One of the senior attendings stood up and said, that is BS. That should not be done. That is malpractice, right? Now it's standard of care. Laparoscopic surgery, minimally invasive surgery, natural orifice surgery. The problem is that these kids, I call them kids because they're my kids' age, when they graduate and are chief residents, They are very good at minimally invasive skills, but they're not sure what to do if and when they need to revert to standard open surgery. I know that sounds silly, but I think I trained at the best time. I can do 500 open gallbladders. Now I convert it to laparoscopic. Yeah, it's the same surgery, but it's a little bit different. So I would love to see more open surgery so they get the anatomy, they get the skill set, they get the touch, the feel, the things you do not get with minimally invasive surgery. And having reviewed lots of cases, I recently reviewed a case where the surgeon took out the wrong piece of colon with the cancer because he lost his tactile feel and only went by the gastroenterologist's report of the colonoscopy, which is we know is not that accurate. That's a problem.
Oh, how horrible. How horrible. Okay, let's shift over to some tech and maybe some future facing content, especially with an AI in healthcare conference and course that we have coming up. I know this is interesting to a lot of our audience. So, how has the rise of AI and data analytics changed what you believe a skilled surgeon looks like today?
Yeah, that is evolving as time is going on. I tell the students to not rely on AI in their patient care. Why do I say that? I did a recent operation with them. Usually they dictate the operative note. I then review it and I make comments or changes based on what we did. What I read that chief resident operative note said is not what we did. And I said to him, what operation? Where I was there with you. What happened? He goes, "Oh no, I just ran it through Chat GPT just to come up with the operative note." I said, that you can't do that, right? Obviously, it's patients have specific everybody comes with different issues. The way we do the surgery might be different. It's the use of templates, which also drives me crazy. Especially, you need to make it patient specific. So, AI is definitely here to stay. There's no doubt. I don't want the residents to rely on that now while they're in their learning process. And I think that that's what we need to emphasize.
You spoke about some of that in our last um, episode as well. So clearly there's consistency in that. You wrote about the need for systems thinking. Is there a particular failure or success story in your own career that illustrates why that's so essential?
Well, I go back to, the nursing care, where the nurses are the eyes and the ears of the patients. They spend more time with them. They know the change in the clinical status. As a surgeon, I fly in the morning and round and I fly out of there and I'm not back unless there's a problem. So it's the thing that we need to teach in training, which also seems to be lacking, is getting them involved in the care of your patient. What does that look like? In the morning, if you're there before the night shift leaves, which if you're there at 6 in the morning, the night shift is there another hour, talk to the nurse. What happened last night? Did they spike a temperature? The electronic medical record has made it very difficult. It's information overload. My head's going to explode trying to find out all that piece of information. But I know what I need when I'm rounding in the morning. What were their vital signs? Did they spike a temperature? What's the urine output? Nausea, vomiting, abdominal pain. I did a bowel surgery. So I know what I need. Getting them involved, and that's what I did in practice, is rounding with the nursing staff. Here's the plan for today. This is what I anticipate. This is what I'm looking for. We don't see enough of that. Everybody assumes that because you put it in the electronic medical record, that we all see the information. That cannot be farther from the truth.
It's interesting that you just spoke about a team effort because my next question was going to be, do you think we're still idolizing the lone genius surgeon archetype? And how does that image clash with the realities of today's OR?
Yeah, I mean, and that's the basic premise is that it is a team sport. We are not there, no matter what field you're in, especially in surgery, but you're not there all the time. And you need to rely on your stoma nurse to tell you if there's a change. You need to rely on physical therapy if the patient has a funny gait. You need to rely on your respiratory therapists. They're hearing something funny. They're the experts. So it's definitely a team sport. Again, I think we had a lot less issues 30 years ago because there was more communication, either handwritten in the chart, but they would always call you. And now the assumption is, oh, I documented it. They can look in the chart. Well, I'm not looking at the chart all the time. I have 6 colonoscopies to do, and I'm answering calls, and I'm running back to the office, and right. So definitely, we need to put more emphasis on the young learners to get them involved. If you get the nurses or the ancillary staff in tune with what the plan is for your patient, there will be a much better communication. And verbal communication, maybe I'm old school, is still the best.
Our audience loves learning about lessons through mistakes when our
Mhm.
experts, of course, are willing to share them. You advocate for leadership training. What's one leadership lesson that you learned the hard way and now try to teach your students and pass on?
Yeah, that's a great question. I think probably the lesson I learned the hard way is trying to fix everything myself. For example, when I became section chief, I went around to the people that I supervised and say, I had a bunch of questions. What can I do to make your job easier? Are you having any issues with things? I tried to handle all of the issues that I found on my own without delegating, right? That's a disaster. You can't do everything. Find out what the issues are, see what that individual needs to help, and that will be much better in the long run. Trying to handle it all on your own, trying to solve everybody's problems, that can't be done.
We had a recent writers conference that we held. It was our second annual. We're now planning a third. So I'm actually very curious about your opinion about storytelling in medicine. What role does storytelling play in training future surgeons, in your opinion? And can narrative medicine or reflective writing help close the empathy gap?
Oh, absolutely. And I use the storytelling when I'm at M&M conference based on a lot of the cases I review. And I say, hypothetically, a patient comes in with XYZ. This is what happened. What's the next step? How can you fix it? It's most of us are visual learners. I'm a visual learner. Storytelling to me, it's painting a picture. When I'm talking to the medical students and they're presenting me a case, I if they're not clear, and usually they're not, it's not their fault. They haven't done it before. I say, stop. You're describing me. I'm painting a picture in my mind. 32-year-old man, overweight, hypertensive, diabetic. You need to paint the picture so I can try to figure out what's going on. I think storytelling is key, getting across a point or explaining medicine. And I use it even when I'm talking to patients.
Awesome. I'm very much for that as well, and partly why I created our magazine and our podcasts, et cetera. If surgical education had a board of innovation, what kind of people would you want sitting at that table? Would you want surgeons? Would you want others as well?
Yeah, that's a great question. Definitely old, cranky doctors like me. Because again, I think that I trained at a great time. We did not have electronic medical record. We communicated with each other. We talked to each other. It was open surgery. Talk about the surgery thing. Everything's changed. Now, it's electronic medical record. You put it down, people assumed everything. A lot of the mistakes, a lot of the near misses, a lot of the root cause analysis that I'm involved in at our hospital are for lack of communication. It is amazing to me. Nobody thinks about picking up the phone. You're staring at your phone all day long. We know that. Pick up the phone and call. It's lack of communication. That board should be old, cranky doctors that have been through the trenches. It's one of the things I tell the residents is that um, experience comes from judgment comes from experience. Experience comes from bad judgment. All of us at my level, we have made the mistakes before, not on purpose, made the mistakes, learned from it, and moved on. So that is key. It needs to be a board of seasoned, experienced physicians that have been through the trenches, that have been through all the different things. I tell the residents there is no complication that they can do that I haven't already experienced before. And that's helpful. When you've been through it, you know how to, I can get them out of things or help guide them to try to prevent the next step.
Okay, I'm excited to end on the following question, but before I read that question, I want to remind everyone that's listening that Dr. Cohen is going to be speaking in two of our upcoming conferences that you can join live, as well as gain access to the course once the live is over. So definitely check that out, and I will link those in the copy of this episode. Let's fast forward 20 years. A future resident reads this particular article that you've written. What do you hope that they'll say about how surgical training has evolved?
Yeah, that's a great question. I mean, I'm really looking for, if I'm still alive, I'm looking forward to the next 20 years because it's going to change rapidly. It's the big, one example, the robot surgery now, it's a big machine, $2 million sits there. It's going to eventually be a smaller machine, compact to the patient's bedside where you're scrubbed and manipulating it. That's thing one. Thing number two, AI. I mean, AI is going to completely change how medicine evolves and changes. I think if somebody reads this article 20 years, they're probably going to laugh and say, wow, nobody could anticipate how much things have changed. And I think if I read an article that somebody wrote when I was a resident in 1987, I would be laughing now too, saying, look at all how this all has changed and evolved. I mean, who would have thought that you can watch back when I was an intern in 87, I would have never thought that you can get on the internet, pull up YouTube, and watch a video of the surgery that you're going to do. That's amazing to me, right? I had a textbook and we did it and learned. So it's going to change. And I think 20 years from now, whatever I wrote is going to be outdated.
Dr. Cohen, thank you so much for sharing your time and expertise with all of us.
Thank you so much. Appreciate it.